Good morning, dear friends. Myself, Dr. Vipul Gurjar. I am the head and the professor of the surgery in SPKS Medical College, Vadodara, as well as I am practicing surgeon in Vadodara. Today, we are discussing about the laser in a fistula surgery. Okay, and this is solely is about my opinion. I'm not stating anyone's or I'm not stating about any literature. It is my practical experience only what we are going to hear. The laser in a fistula surgery. See, in my practice, I'm not doing that much laser in fistula surgery, in every fistula surgery, because I'm not getting that much good result in compared to fistulectomy or the fistulotomy. If see Once there is a infection, it is definitely a contraindication to the laser surgery. First thing. Second thing, if it is a smaller tract like a 1 centimeter or 2 to 3 centimeter in tract, the fistulectomy or the fistulotomy is the gold standard nowadays in compared to the laser surgery. Now, what is the role of laser surgery? If you are not able to do the sphincter repair, and if you want to go for the smaller wound with the explanation about the recurrence of the surgery, or third thing, the patient's demand is this: I want to go for the laser surgery only. So the recommendation of using a laser from internal opening to external opening, it is not ideal practice, because this type of pure laser surgery, ablation of tract from internal to external opening, is failure is more happen. So ideally, if you want to go for the laser surgery, then it should be a hybrid technique. That means dealing of internal opening or dealing up to the crypto gland with the your choice of surgery, like a slot, lift, primary excision. It's your choice. And later, the dealing with the distal tract with the laser is the it must be the choice of your treatment. Now, then what is the advantage of doing this laser in a distal tract? That it gives less scar, less wound, so the recovery will be very good. But the what are the problem of using this laser? Before that, I will explain how to do. Okay. See, whatever the choice, it's depend you from the proximal tract up to the crypto gland. Okay, it may be excision, lift, or the slot. Time of distal tract. Now you start your machine. You keep your machine up to the 10 to 12 watt. Okay, as well as you put this machine in only in the continuous watt or the dual watt machine. Must be use a radial fiber only. Only the radial fiber is accepted for the fistula surgery. Now you just enlarge or the external opening, then push this radial fiber up to the ligation area, then start the machine one per centimeter per millimeter per second withdrawal. And after giving this all energy, this because of this laser energy, the intimal lining of tract of fistula becomes a damaged one. So after this damaging, you use a scoop to scrape out this old internal lining. Okay, so laser is not utilized for the obliteration of tract. Laser is utilized for the damaging internal lining epithelialization of the tract. So you need to do the scrapping, full scrapping of all tract. Then further you can utilize, put the same, repeat with the same thing, and next time, a third time, you can use with the low laser machine with the same fiber, and try to give some pressure distal to the tip of radial fiber once you are withdrawing. So it will help to obliterate the cavity later on because of the formation of hemocoagulum inside the cavity. It is not that much important, but you can utilize this technique to obliterate the tract. Okay, you keep the external wound somewhat a larger size because there will be a continuous pus, or the discharge of the seroma or blood will definitely comes out later on, or you can give the some wash also. So you enlarge the external wound. Okay, and in my practice this type of this distal ablation with the laser, there is a huge chances of recurrence because the fistula tract is not always same. That means you can't consider then 1 month old fistula, 2 month old fistula, 3 month old fistula, 1 year old fistula. In your practice you may feel that after the one patient you are dealing with the coring of the fistula of 1 year or 2 year old, the fibrous tract is so much hard you are not able to cut the with the scissor also. Then how can do with the exercise with the laser? So it's depend upon the chronicity of track also. So you have to change the energy and the scraping and multiplication of this process depending upon the chronicity of the track. Okay. In compared to lift slope, I definitely preferred the proximal excision and distal ligation, which is mainly promoted by the Dr. Shukla Sahib in many conferences. And I think we should go this technique. It is somewhat acceptable technique if you are using a laser for the fistula surgery. In my practice, I am doing the laser surgery in a fistula almost only 20 to 30 percentage case only. It is reserved on my practice or the patient's demand only, because long-term data is not gathered in a practice, as well as long-term follow-up also not gathered in my practice also. So I am somewhat hesitant to use a laser in a fistula surgery. Thanking you. If you have any query, please send me message. We'll try to solve your problem. Thank you very much.